Intermediate uveitis from Namrata Sharma. I'm just going to read it. Introduction. As per its anatomical definition, intermediate uveitis (IU) is defined as an inflammation involving the anterior vitreous highlightis, ciliary body, posterior part of ciliary body, and peripheral retina. Nomenclature. Various names were used to describe the condition, including chronic cyclitis, vitritis, cyclochorioretinitis, pars planitis, intermediate uveitis, peripheral uveitis, etc. Recently, as per the SUN, that is Standardization of Uveitis Nomenclature, IUSG, Working Group's guidelines, IU refers to the subset of uveitis wherein the major site of inflammation is vitreous and there is an associated infection or systemic disease. The term pars planitis refers to the idiopathic subset of intermediate uveitis occurring in absence of any associated infection or systemic disease. Pars planitis forms the majority subset of intermediate uveitis as high as 70 to 80%. Also note that intermediate uveitis means the major site of the inflammation is vitreous and it is associated with any infection or systemic disease causing the vitritis or inflammation of the uvea. So that is intermediate uveitis, intermediate part of the uvea, that is pars plana. But pars planitis term, it refers to the idiopathic subset of intermediate uveitis occurring in the absence of any associated infection or systemic disease. It is idiopathic. So pars planitis, it forms a majority subset of intermediate uveitis as high as 70 to 80% of the cases. So if there is vitritis and no other signs and symptoms of anterior uveitis or pan-uveitis and intermediate uveitis, vitreous cells, then in 70 to 80% of the cases it's going to be idiopathic. That is pars planitis, because pars planitis forms the majority subset of intermediate uveitis as high as 70 to 80%. Also note that involvement of vessels in form of peripheral vascular sheathing and cystoid macular edema does not change the nomenclature or classification. So there is involvement of the vascular sheathing, vessels, vascular sheathing is there, cystoid macular edema, association of these things, it doesn't change the nomenclature or classification. Intermediate uveitis is usually given as a long case or a short case in the exams. History. Chief complaint. The condition may have minimal symptoms. Unlike anterior uveitis, the symptoms are bilateral more than unilateral and often asymmetrical. The symptoms are bilateral more than unilateral and often asymmetrical. The minimal symptoms. So laterality, it is bilateral in most cases and asymmetric bilateral involvement in most cases. Also, the disease may present with its complications like cystoid macular edema, vitreous membranes, glaucoma, and cataract. The usual presenting complaints are floaters, the most common due to snowballs, membranes, and vitreous opacification. Blurring of vision, chronic painless due to cystoid macular edema, cataract. Loss of vision, sudden painless due to glaucoma, spillover uveitis. Sudden painless loss of vision is due to glaucoma, spillover uveitis. Secondary rhigmatogenous retinal detachment, that is rare, noted during routine fundus examination or evaluation. History of present illness. Intermediate uveitis tends to affect young individuals with a bimodal distribution. Bimodal distribution means it peaks at two ages. Intermediate uveitis tends to affect young individuals with a bimodal distribution, that is, affecting two age groups, 5 to 15 years and 20 to 40 years. 5 to 15 years and 20 to 40 years, that is, pre-teen age almost, 5 to 15 years and 20 to 40 years, that is middle age, middle young age. Equally affecting males and females, affection of gender equal, age group bimodal representation or bimodal distribution. It is 5 to 15 years and 20 to 40 years. Some reports from India put it as the most subtype of uveitis in children, whereas others report it as the least common. So, in some parts of the India, the common subtype of uveitis in children is reported as the intermediate uveitis, and in other reports it is the least common. Unlike anterior uveitis, it has an insidious onset. Insidious means it is not sudden, it's gradual. The most common presenting symptoms are floaters. Associated pain, redness, watering is usually absent or may be present in children with associated anterior uveitis. These are usually minimal when present and often seen as spillover anterior uveitis. So, pain, redness, watering are absent, may be present in children, especially when they are associated with anterior uveitis in case of spillover anterior uveitis. Patient may have history of similar episodes in the past with remissions, may have a chronic history without remissions. Patient may complain of chronic worsening of vision or a sudden worsening of vision in a background of long-standing history. So, patient may have history of similar episodes in the past with remissions or may have a chronic history without remissions. Similar episodes in the past with remissions or may have chronic history without remissions. Now, similar episodes in the past, obviously, with remissions means recovery. Remissions means recovery. It is interrupted by recovery period, recurrent this one, and if there is no, it is not interrupted by the recovery period. Obviously, it's going to be chronic. So, chronic history without remission or similar episodes with remission. Patient may complain of chronic worsening of vision or a sudden worsening of vision in a background of long-standing history. History of past illness. Past medical and surgical history must include careful history to rule out the systemic association or etiological causes of intermediate uveitis. There may be past history of associations of intermediate uveitis as well. For example, sarcoidosis, tuberculosis, multiple sclerosis, etc. Even on absence of symptoms, leading questions must be asked for commonly associated disorders, as intermediate uveitis may be the primary presentation. Flowchart 1. Family history. Intermediate uveitis, though not hereditary, has been seen reported in families. It is associated with HLA-DR15 and HLA-DR51 alleles. Intermediate uveitis is seen in families with common HLA haplotypes. Also note that HLA-DR15 is associated with multiple sclerosis and thus may suggest a predisposition of it in patients with intermediate uveitis with HLA-DR15 positivity. So, family history. Intermediate uveitis, though not hereditary, it is not hereditary. It has been reported in some families when associated with certain systemic diseases. For example, HLA-DR15 and HLA-DR51 alleles. Intermediate uveitis seen in families with common HLA haplotypes 15 and 51. HLA-DR15 and HLA-DR51 means HLA-DR15 and 51 alleles. IU is seen in families with common HLA haplotypes, Also note that HLA-DR15 is associated with multiple sclerosis. So HLA-DR15 is associated with what autoimmune disorder? Systemic disorder, that is CNS disorder, multiple sclerosis, and thus may suggest a predisposition of it in patients with IU with HLA-DR15 positivity. Examination, general examination. Detailed systemic examination is warranted to know any associated conditions like sarcoidosis, tuberculosis, multiple sclerosis, signs of tick bite or Lyme's disease. The following conditions are associated with intermediate uveitis. Now, police, pelo, edema, then lymphadenopathy in Lyme's disease, cat scratch disease, tuberculosis, and sarcoidosis. There is a lymphadenopathy. Then paleness. Paleness here is not that significant as long as I'm seeing these conditions, most common conditions associated with intermediate uveitis. Edema also, skin examination, rashes, erythema migrans, erythema nodosum, sarcoidosis, and Lyme's disease, that target sign or bullet sign or target, bull's target sign, that skin rash lesion at the site of bite. In case of the Lyme's disease, that is a tick bite disease, the following conditions are associated with intermediate uveitis. Now, flowchart 1 that we'll see here. Flowchart 1, flowchart depicting common causes of intermediate uveitis. Intermediate uveitis: infectious, inflammatory, idiopathic, and others, that is masquerades. Infectious: tuberculosis, Lyme disease. Lyme disease is Borrelia burgdorferi. Cat scratch disease is Bartonella Hansley. Toxocariasis, Toxocara catis and canis, Tuberculosis, Lyme disease, cat scratch disease, Bartonella Hansley, burgdorferi, these are bacteria as long as I remember. Toxocara canis and catis, these are parasites. Tuberculosis, Lyme disease, cat scratch disease, and toxocariasis. Inflammatory conditions, sarcoidosis and multiple sclerosis. Idiopathic, pars planitis. Others, masquerades, for example, lymphoma, intraocular foreign body, amyloid. Masquerades means something miscellaneous kind of category. For example, lymphoma, tumors, or some foreign body, intraocular foreign body, amyloid, which are not exactly, is not fitting into this infectious and systemic inflammatory causes. These are so masquerades or miscellaneous: lymphoma, intraocular foreign body, and amyloid, etc. Now, ocular examination, visual acuity. CNS examination in case of the multiple sclerosis is very important. Respiratory examination in case of the tuberculosis and sarcoidosis is important. Heart diseases, as long as in syphilis, usually panuveitis, but syphilis, there can be involvement of the cardiovascular system also, CNS also. It's like widespread. So, ocular examination, visual acuity. The visual acuity is usually normal in early cases. Patient may have vision acuity of 6/6, with floaters being the only complaint. Main cause of decreased visual acuity in intermediate uveitis is development of cystoid macular edema, CME. Other causes of dimness of vision include development of cataract, dense vitreous membranes or opacities, epiretinal membrane, vitreous hemorrhage from neovascularization, tractional or rhigmatogenous retinal detachment. So, visual acuity, it is normal, but only complaint can be floaters in most cases. And if there is decrease in the visual acuity, it is mainly because of the cystoid macular edema. Rarely, when there is a sudden loss of vision, then it is retinal detachment. And associated conditions can be there, which lead to decrease in the vision. For example, cataract, dense vitreous membrane, opacities, epiretinal membrane, vitreous hemorrhage from neovascularization, complications of it, tractional or rhigmatogenous retinal detachment, even the glaucoma, but there will be pain and redness with that. Eyeball, squint may be present, but is a consequence of complications of a disease due to loss of fusion. Squint can be present, but it is a consequence of complications of a disease due to loss of fusion. Lead or conjunctiva or cornea or sclera are usually within normal limits. There may be aponeurotic ptosis or in rare cases enophthalmos as a side effect of previous treatment in form of periocular steroid injections. Scleritis, there can be patient might have gotten the treatment for it previously during the previous episodes with the steroid injections, and there can be aponeurotic ptosis because of that in rare cases, and enophthalmos can be because of the steroid injections recurrent intermediate uveitis attacks. Scleritis may be present. The disease is then called sclerouveitis. Keratic precipitates may be present, that is spill over to anterior segment, anterior chamber, causing anterior uveitis. In fact, IU is characterized by KPs that may be central rather than typical inferior arch triangle KPs of anterior uveitis. Arch triangle KPs of anterior uveitis. Arch triangle KPs, which are seen in anterior uveitis in inferior cornea. But in intermediate uveitis, if the KPs are there, then these are central. Anterior chamber, it may show variable number of spillover anterior chamber cells or flare spillover, that is extension of the infection, anterior extension of the infection. These should be carefully documented as per the Sun classification standardization for uveitis nomenclature. Now, grading of anterior chamber cells as per standardization of uveitis nomenclature, Sun Workshop 2004 consensus. The cells are counted in a dark background of an undilated pupil in a slit of 1 mm by 1 mm. The slit size of the beam should be 1 by 1 mm, and higher magnification, that is 20x. So grade and number of cells, 0 is less than 1 cell, that is no cells. 0.5 means 1 to 5 cells. 0.5 plus means 1 to 5 cells. 1 plus means 6 to 15. So 1 to 5 cells, 0.5 plus. 1 plus means 5 to 15 cells. Then 2 plus means in that slit 1 by 1 mm you will see 16 to 25 cells. 2 plus means 16 to 25. 3 plus means 26 to 50, and 4 plus means over 50. So standardization of uveitis nomenclature grades: 0 no cells, 0.5 means 1 to 5 cells, then 1 plus means 6 to 15 cells, then 2 plus means 16 to 25 cells, 3 plus means 26 to 50 cells, and 4 plus means 50 plus cells, more than 50. Now pupil is circular as there is no or minimal anterior chamber reaction and usually no synecdoche. Pupillary reflexes are usually within normal limit unless complicated by retinal detachment, which is a rare complication of intermediate uveitis. Intraocular pressure. A rise in intraocular pressure may occur, especially as a complication in intermediate uveitis due to steroid or secondary glaucoma. So intraocular pressure, it can be raised, but because of the steroid use and because of the secondary glaucoma as a complication of it. A rise in intraocular pressure in uveitis is also associated with increasing age. Duration since diagnosis and active inflammation. Intraocular pressure may be low in case of severe reaction and formation of cyclitic membrane. So intraocular pressure measurement, why it is significant in case of the intermediate uveitis. First thing, it can be There can be decrease in the intraocular pressure because of the cyclitic membrane, because of the inflammation. There can be atrophy of the pars plana, that portion, and antispele of the inflammation, the ciliary body, pars plicata, and that can lead to the cyclitic membrane, ciliary body atrophy, and that can lead to the decrease in the aqueous humor formation and decrease in intraocular pressure. That is hypotony. And then second, increase in the intraocular pressure. It usually doesn't occur in isolated intermediate cases, but as a complication of it, due to antispele of the infection, clogging the trabecular meshwork with the cells with anterior uveitis, as a complication of it, anterior extension of it, or secondary to steroid use to treat this intermediate uveitis. Now lens, cataract may occur in 50 to 60% of the cases and is one of the causes of decreased vision in intermediate uveitis. Posterior subcapsular cataract is the most common cataract associated. However, even anterior subcapsular cataract may be found. Cataract in intermediate uveitis may be due to chronic inflammation or long-term steroid treatment or glaucoma medications, especially cholinergic agents. Lens, cataract may occur in 50 to 60% of the cases and is one of the causes of decreased vision in intermediate uveitis as a complication or in age, but usually, if it is in the old age. Posterior subcapsular cataract because of the steroid, because of the age, because of the complication. PSC is the most common cataract associated with intermediate uveitis. However, even anterior subcapsular cataract may be found. Cataract in intermediate uveitis may be due to chronic inflammation or long-term steroid treatment. Causes: chronic inflammation or long-term steroid treatment or glaucoma medications, especially cholinergic agents, pilocarpine, used in the treatment of uveitis and uveitic glaucoma. Retrolental space should be carefully examined for cells which is pathognomic for present or past anterior vitreous inflammation. However, presence of these cells does not indicate active disease. Vitreous haze should be noted and graded. Table 2. Increasing vitreous haze is a sign of activity and decreasing vitreous haze is a sign of response. Vitreous haze should be noted and graded. Table 2. Increasing vitreous haze is a sign of activity and decreasing vitreous haze is a sign of good response to the treatment. So, table 2, grading the vitreous haze. NEI, grading of vitreous haze as adopted by the standardization of uveitis nomenclature SUN working group. So 0 means no inflammation, normal fundus view. 0.5 plus means some media haze is present, no fiber layer striations not able to be visualized, but disc and retinal vessels are seen distinctly. So it is dependent on the visibility of the nerve fiber, disc and retinal vessels. Nerve fiber, vessels and disc visibility. Now 0.5 plus means no fiber layer striations we cannot see. 0.5 plus means some media haze is present, no fiber layer striations not able to be visualized, but disc and vessels are seen distinctly. 1 plus means vitreous cells and haze present. So 1 plus, vitreous cells and haze present, but optic nerve head and retinal vessels clearly visualized. So in 0.5 plus, nerve fiber layer can be seen but striations are not visible. In 1 plus, nerve fiber layer cannot be seen but optic nerve head and retinal vessels are clearly visualized. 2 plus means retinal vessels visualized better, optic nerve head is hazy. So retinal vessels are visualized better and optic nerve head is hazy in 2 plus. 3 plus means retinal blood vessels are not visualized and optic nerve head is hazily visualized. 4 plus is optic nerve head not visualized. So 0 means no inflammation, normal fundus view. 0.5 plus means some media haze is present, no fiber layer striations are not seen. No fibula is seen, but striations are not seen. Disc and vessels are seen distinctly. 1 plus means vitreous haze is present, cells present, but optic nerve head and vessels are clearly visualized. 2 plus means retinal vessels are seen, optic nerve head is seen, but hazy view. Then 3 plus means retinal blood vessels are not seen, but optic nerve head is seen, but it is hazy. Then 4 plus means optic nerve head is not visualized in 4 plus vitreous haze. Now coming to ocular examination once again, vitreous. Vitreous is the major site of inflammation in intermediate uveitis. Thus, inflammatory cells mainly accumulate in the vitreous cavity in the form of retrolental cells. Vitreous membranes may condense as snowballs or may settle down inferiorly over retina or pars plana as snow banking, leading to variable degrees of vitreous haze. Snowballs appear as yellow-white condensations in mid-vitreous, especially inferiorly. Snowballs, these are how these are seen. These are seen as yellow-white condensations, yellow-white opacities or condensations present in the mid-vitreous, and these are present especially inferiorly. Snow banking means more severe inflammation, and snow banking appears like exudates over the pars plana, especially inferiorly, but may be seen all around. Scleral indentation or use of Goldman 3-meter contact lens. Scleral indentation, because if you want to see the snow banking at the pars plana, you have to indent the sclera. We cannot see it. Pars plana we cannot easily see. We have to indent the sclera to see it on the IDO. And then use of Goldman 3-meter contact lens may be required to view peripheral retina and pars plana. Sometimes vitreous haze may be severe enough to obscure view of fundus, preventing further examination. Early posterior vitreous detachment may be seen. So vitreous examination, obviously cells, vitreous haze, then grade the vitreous. Then what we'll see? We'll see the snowball opacities floating in the mid-vitreous, especially inferiorly, because they are heavy under the effect of the gravity. Inferiorly, they are seen more in the mid-vitreous, and these are seen as yellow-white condensations or opacities. And snow banking means settle. When the snowballs, they settle down and they form the fibromuscular membrane or exudates. They settle down inferiorly on the pars plana. They settle down inferiorly anywhere in the vitreous, in the retina part, anywhere in any quadrant, especially inferiorly. That is the snowball. It is inflammation, but snow banking is more severe inflammation than snowballs. So that is important, and there can be early posterior vitreous detachment. Fundus. If media clarity permits, examination of retina must be done carefully in all cases of intermediate uveitis. The fundus findings in intermediate uveitis includes fundus examination. If media clarity permits, examination of retina must be done carefully in all cases of intermediate uveitis. The fundus findings in intermediate uveitis includes tortuosity of the vessels. Fundus findings: tortuosity of the vessels, involvement of the peripheral retinal vasculature in form of sheathing, periphlebitis, neovascularization, which is usually peripheral near the area of snow banking. Peripheral vitreous traction and hole formation due to contraction of inflammatory membranes may be seen. Retinal detachment has also been reported as a complication of intermediate uveitis. Peripheral choroiditis may also be seen, though severe choroidal involvement indicates review clinical diagnosis. So fundus examination, there can be tortuosity of the vessels. There can be periphlebitis, obviously peripheral, mid-peripheral periphlebitis. Vascular sheathing can be present. Then sclerosed vessels when the sheathing is very advanced and complete. Neovascularization, which is usually peripheral near the area of the snow banking. Snow banking settle down exudates. Peripheral vitreous traction can be there because of the snow banking, epiretinal inflammation, epiretinal membrane formation, or PVD association. There can be peripheral vitreous traction because of the inflammation, and there can be hole formations, and due to contraction of inflammatory membranes can be seen, that can lead to the rhegmatogenous retinal detachment. as a complication of intermediate uveitis, but it is rare. Peripheral choroiditis may also be seen. Choroiditis, peripheral. Though severe, choroidal involvement indicates review of clinical diagnosis. There can be spill-off infection, there can be glaucoma, cataract as a complication. But fundus examination, tortuosity of the vessels, periphlebitis, sheathing of the vessels, periphery, mid-periphery, neovascularization near the adjacent areas to the snow banking. Then posterior vitreous detachment, peripheral vitreous traction can be present, epiretinal membrane can be present, there can be holes, there can be tear, there can be retinal detachment. RD is very rare. Now differential diagnosis for this intermediate uveitis: vitreous membranes, vitreous degeneration, leukemia, lymphoma, endophthalmitis, panuveitis, amyloidosis, old vitreous hemorrhage. So differential diagnosis: if there is vitreous haze and vitreous cells, what can be there? Post-operative vitreous haze can be there. There can be vitreous degeneration, old vitreous hemorrhage, leukemia, lymphoma, endophthalmitis, panuveitis, amyloidosis, vitreous membranes. Once again, differential diagnosis for vitreous intermediate uveitis or vitritis in the intermediate uveitis: vitreous membranes, vitreous degeneration, leukemia, lymphoma, vitreous membranes, vitreous degeneration, old vitreous hemorrhage, then panuveitis, endophthalmitis, leukemia, lymphoma, endophthalmitis, amyloidosis. Investigations in case of intermediate uveitis or pars planitis: systemic evaluation. As previously mentioned, many infections and systemic conditions are associated with intermediate uveitis IU. A careful history, ocular examination, and ancillary or laboratory tests should be carried out to search for the etiology or associated condition. The test may include complete blood count with differential count and erythrocyte sedimentation rate (ESR), purified protein derivative skin test (PPD), purified protein derivative test (PPD) for TB, obviously, Mantoux test, that is, chest X-ray to look for evidence of pulmonary tuberculosis or sarcoidosis, chest X-ray to look for evidence of pulmonary tuberculosis or sarcoidosis, serum angiotensin converting enzyme levels in case of the sarcoidosis, ACE, are raised. Serum angiotensin, serum ACE, serum angiotensin converting enzyme levels are raised in sarcoidosis. Gallium scan, MRI brain for multiple sclerosis, Lyme titers and Western blot if high suspicion in endemic areas. Lyme titers, that is ELISA or ELISA, IgG, and Western blot if high suspicion and in endemic areas. The list is very large and should be based on a tailored workup. Refer to flowchart 1. If you are suspecting any cause, accordingly you should choose the investigations rather than bombarding the patients with lots of investigations, unnecessary investigations. In Indian subcontinent, TB should be ruled out in all the cases. Masquerades should be considered whenever applicable. Ocular investigations, ultrasonography, B-scan, to be done to rule out complications like retinal detachment in cases where intense inflammation leads to severe media haze, preventing the fundus evaluation. It may also help out to rule out conditions masquerading as intermediate uveitis like intraocular tumors. So ultrasonography when there is vitreous haze and we cannot see the retina. Ultrasound biomicroscopy to demonstrate the pars plana exudates when clinical examination is difficult in presence of media opacities. If there is media opacities, we cannot demonstrate any reason of media haze, or media haze is there, then ultrasound biomicroscopy can be done to ensure the pars planitis or intermediate uveitis, which demonstrates the pars plana exudates. Optical coherence tomography (OCT) to document presence of cystoid macular edema, especially in patients with complaint of diminished vision, central vision. It can be used to guide to therapy. OCT in cystoid macular edema, and also as a guide to therapy in case of the cystoid macular edema. Choroidal thickness should also be monitored once treating concomitant choroiditis. Later on, epiretinal membrane and tractional changes can also be seen on studying the virtual reality VR interface. So, optical coherence tomography in case of the cystoid macular edema for diagnosis and also management, its treatment, to see the progression of the treatment of cystoid macular edema, first thing. Then progression of the SCMA. Then second thing, we can see the vitreous detachment on it. We can see the epiretinal membrane if it is present over there. We can also see the choroidal thickness if it is associated with the choroiditis. Fluorescein angiogram shows presence of peripheral capillary non-perfusion, peripheral neovascularization, presence of retinal vasculitis and petaloid, and honeycomb leakage suggestive of cystoid macular edema, CME. Fluorescein angiography may also be helpful for follow-up after cryotherapy or laser photocoagulation treatment. Fluorescein angiogram when capillary perfusion area capillary non-perfused areas in case of the cystoid macular edema, honeycomb leakage in cystoid macular edema, petaloid appearance in cystoid macular edema, then periphlebitis if there are any leakage sites or capillary non-perfused areas, or in case of NVE if there is any leakage NVE. Fluorescein angiography may also be helpful for follow-up after cryotherapy or laser photocoagulation treatment. Ultrawide imaging helps in documenting peripheral changes. Ultrawide field fluorescein angiography may also help in documenting peripheral CNP areas and presence of peripheral neovascularization. Complications of intermediate uveitis, cataract, glaucoma, cystoid macular edema, epiretinal membrane, vitreous hemorrhage, retinal detachment, rarely optic disc edema. Complications of intermediate uveitis or pars planitis, cataract, glaucoma, cystoid macular edema. From posteriorly, cystoid macular edema, epiretinal membrane, then neovascularization, traction, retinal detachment, retinal holes, retinal tears, rarely optic disc edema, rarely retinal detachment, then anteriorly cataract, that is posterior subcapsular cataract due to steroid or inflammation, then glaucoma, anterior spillover of the infection, inflammation or infection, whatever. Management. If an etiology has been identified on investigation, treatment depends on the cause. In case where no specific etiology has been identified, following are the management options. First, treat the cause, find out the cause and treat that cause. And if there is no cause, if it is idiopathic case, then following are the management options. If there is cystoid macular edema, then it should be managed. It should be managed conservatively by observation, depends upon the visual acuity. A 4-step approach for the treatment and intermediate uveitis was proposed by Kaplan. 4-step approach for the treatment of intermediate uveitis by Kaplan. It should be remembered that every case may not need treatment. Every case may not need treatment. Kaplan. 4-step approach, and every intermediate uveitis case may not need the treatment in absence of media haze less than 1 grade 1, that is 0.5 plus, in cases with only few inferior snowballs and absence of complications like CME. Just meticulous frequent observations may suffice. Following are the management options: step 1, then step 2, step 3 and step 4. Kaplan's four-step approach for treatment of the intermediate uveitis. Now, step 1, infections should always be ruled out if planning for steroids. If you are planning to treat the intermediate uveitis, then first rule out any infectious cause of the intermediate uveitis. Periocular steroids may be considered as initial treatment. Periocular steroids, initial treatment modality is periocular steroids, especially in which condition? Uniocular conditions. Subtenon injection is the most common route for depot corticosteroids. What are depot corticosteroids? That will see. So depot corticosteroids like depomedrol, methylprednisolone acetate, are a type of corticosteroid that is formulated for slow and sustained release after a single injection, that has slow and sustained activity after a single injection, providing relief from inflammation and other conditions for weeks to months. So depomedrol, that is methylprednisolone acetate, is a common brand name for a depot corticosteroids. Other brand names include depomedrate and depomedron. So what is that? Methylprednisolone acetate. Other route for local therapy includes intravitreal corticosteroid injection. In case of failure of depot steroids, if there is a failure of depot steroids, and in bilateral cases, systemic corticosteroids could be considered. So first, uniocular cases, local steroid injection, subtenon, depot corticosteroid, that is methylprednisolone acetate. Second, intravitreal corticosteroid injection when the local therapy fails, like this. And if there is failure of therapy with depot steroids, and if there is a bilateral case, if it's a bilateral case, then systemic corticosteroids could be considered. So local subtenon, intravitreal steroid injection, and then if failure and bilateral case, then systemic corticosteroids. In cases with cystoid macular edema, periocular steroids help by maintaining a constant influx steroids. Presence of CME should indicate an alerting sign warranting aggressive therapy, as it may lead on to a permanent visual loss. It can lead to a permanent visual loss. Then we should not wait. We should not just observe the case. We should actually treat it with a steroid. Throughout therapy, patients should be monitored for ocular and systemic side effects of steroids. But we have to rule out any infectious cause for the steroid if it is CME. Throughout the therapy, patients should be monitored for ocular and systemic side effects of steroids, which can be debilitating at times. Dietary supplementations for calcium should also be considered. A more recent advancement is use of sustained release of steroid implants like Ozurdex and Retisort. More sustained release of steroid implants. Now, depot steroids different, steroid implants are different. Steroid implants are Ozurdex and Retisort. Depot steroids, then steroid implants. Ozurdex and Retisort. These have now been approved for ocular use in non-infectious uveitis. They work well in isolated ocular disease, but complications should be monitored. They recently conducted multi-center uveitis steroid treatment, MUST, multi-centered uveitis steroid treatment. They recently conducted must study, that is multi-center uveitis steroid treatment. MUST stands for multi-center uveitis steroid treatment, multi-center uveitis steroid treatment study, which is recently conducted, has shown good results with fluocinolone implant when compared to systemic therapy. When it is compared to the systemic therapy, fluocinolone steroid implant, it has shown better results when it was compared with systemic therapy. Now, step 1 was about local injection, uniocular, periocular steroid, subtenon injection, depot, that is methylprednisolone acetate. Second, if failure, then go for intravitreal corticosteroid injection. Then if that fails and if it is a bilateral case, then go for systemic corticosteroids. But when using the corticosteroids, rule out any infections. And then if it is hysteromacular edema, we should not just wait and observe. We should actually use steroids, ruling out any infections. And even calcium dietary supplementations can be given if the patient is on steroid treatment. Then they have observed the steroid implants Ozurdex retisert. In case the recently carried out study MUST, that is multi-center uveitis steroid treatment study, it has shown that it has shown the good results with fluocinolone implant when compared to systemic therapy. Fluocinolone implant. Ozurdex is dexamethasone implant, slow sustained release, and retisert is what? And retisert is fluocinolone acetonide intravitreal implant, 0.59 mg. Retisert is fluocinolone acetonide intravitreal implant, 0.59 mg. So Ozurdex implant is dexamethasone implant. Its dose is, one implant has 0.7 mg. It's mg. And retisert, it is fluocinolone acetonide, and its dose is 0.59 mg, intravitreal implants. So that was about the step 1 approach to treat the intermediate uveitis according to Kaplan. Now step 2. Step 2, peripheral retinal ablation over snowbank near sparse planar region may be considered in case of non-response to peribulbar steroids. Peripheral retinal ablation over snowbank near pars plana region may be considered in case of non-response to peribulbar steroids. Peripheral retinal ablation over snowbank, where exactly? In the over the pars plana region. Peripheral retinal ablation over pars plana region near the snow banking. Peripheral retinal ablation over snow bank near pars plana region may be considered in case of non-response to peribulbar steroids. This may be done either by using cryopexy, double freeze thaw technique, or peripheral scatter photocoagulation, laser treatment or cryo treatment. Peripheral scatter photocoagulation or cryopexy, double freeze thaw technique. What is cryotherapy? In ophthalmology, cryotherapy uses intense cold to treat certain eye conditions with cryogens like liquid nitrogen. Boiling point is minus 196 degrees centigrade, carbon dioxide snow minus 79 degrees centigrade, or argon gas minus 35 degrees centigrade, reaching temperatures as low as minus 80 degrees centigrade to destroy or scar tissue. In ophthalmology, cryotherapy, it uses intense cold and cryogens, liquid nitrogen, then carbon dioxide snow, then argon gas. So carbon dioxide, liquid nitrogen, and argon gas, liquid nitrogen, carbon dioxide snow, and argon gas. Liquid nitrogen minus 196 degrees centigrade, carbon dioxide snow minus 79 degrees centigrade, argon gas minus 35 degrees centigrade, reaching temperatures as low as minus 80 degrees centigrade to destroy a scar tissue. Other cryogens: freon, boiling point minus 29.8 degrees centigrade to minus 40.8 degrees centigrade, or nitrous oxide, boiling point minus 88.5% or 5 degrees centigrade. The temperature range for cryotherapy from minus 20 degrees centigrade to minus 80 degrees centigrade, depending on the cryoprobe size, duration of freezing, and the cryogen used. So, retinal cryopexy means it creates a scar tissue to seal the retinal tears and prevent further damage or retinal detachment. So what are the cryogens? Liquid nitrogen minus 196 degrees centigrade, carbon dioxide snow minus 79 degrees centigrade, argon gas minus 35 degrees centigrade. Other cryogens: freon minus 29.8 degree to minus 40.8 degree, nitrous oxide minus 88.5 degrees centigrade. The temperature range for cryotherapy minus 20 degrees centigrade to minus 80 degrees centigrade. This may help decrease the risk of bleeding and regression of neovascularization. Recent studies indicate primary role of cryotherapy as the first measure also. However, this treatment may lead on to temporary worsening of the disease as well. So if the patient is not responding to peripheral steroids, then one can go for retinal ablation over the snow banking near pars plana region. For that, one can use the cryotherapy or peripheral scatter photocoagulation. Now, step 3 of Kaplan's approach to treat the intermediate uveitis. Step 3 is pars plana vitrectomy. Pars plana vitrectomy with induction of posterior vitreous detachment. Pars plana vitrectomy with induction of posterior vitreous detachment and peripheral laser is helpful in cases resistant to previous modalities and in whom immunosuppressive therapy may be contraindicated. This is particularly helpful in cases with decreased vision due to severe media haze with vitreous membranes, in cases of vitreous hemorrhage, in cases with non-responding CME, or cases complicated with retinal detachment or ERMS, epiretinal membranes. Step 3 is pars plana vitrectomy with induction of posterior vitreous detachment and peripheral laser. So when it is done when step 1, step 2 failure, step 1, step 2 failure, that is local steroids, systemic steroids, they fail to treat it, implants, they fail to treat it, cryotherapy, scatter photocoagulation, they fail to treat intermediate uveitis. And when the intermediate uveitis, there is a severe media haze because of the vitreous hemorrhage, epiretinal membranes, non-responding cystoid macular edema, and retinal detachment, then go for pars plana vitrectomy with posterior induction of the posterior vitreous detachment and peripheral lasers. And also in patients in whom the immunosuppressive therapy may be contraindicated. Now, step 4. Step 4 is systemic immunomodulatory therapy is of special benefit in bilateral cases. Chronic and frequently relapsing cases may benefit due to laser steroid dependence. Further, volcosporin Lux Uveitis multi-center investigation of a new approach to treatment, Luminate. Lux Uveitis multi-center investigation of a new approach to treatment study is showing promise as a steroid sparing agent. It is showing as a promise. So, systemic immunomodulatory therapy with what? Volcosporin, according to Luminate study. What is Luminate? Lux Uveitis multi-center, I for investigation of a, and for new, A for approach, T is to, a treatment study. Luminate study, that is Lux uveitis multicenter investigation of a new approach to a treatment, volcosporin. It is showing promise as a steroid sparing agent in treating intermediate uveitis. Systemic immunomodulatory therapy, when it is done, if it is a bilateral case and it is chronic case or frequently relapsing cases, they benefit because chronic treatment with the steroid is, because of the steroid side effects, better to go for volcosporin like systemic immunomodulatory therapy. That is the step 4 of the Kaplan's approach. One, first treatment, local systemic steroids, implant steroids. Then step 2 was peripheral retinal ablation with cryotherapy or peripheral scattered photocoagulation. Step 3 is pars plana vitrectomy with induction of the posterior vitreous detachment and peripheral laser. Step 4 is systemic immunomodulatory therapy, volcosporin LUMINATE study. Another study in step 1 was what? That was MUST study, that is multicenter uveitis steroid treatment. They studied what? Fluocinolone implant, 0.59 mg intravitreal implant. It showed good results when compared to the systemic therapy of the steroids. Note, the treatment plan may not necessarily follow the stepwise approach, and a combination of one or more modalities may be considered as per individual cases and to achieve early remission or decrease the duration of corticosteroids. Now, Viva questions. What is the most common presenting symptom in case of intermediate uveitis? The patients most commonly present with symptoms of floaters in a case of intermediate uveitis. Most common presenting symptom in case of intermediate uveitis? Floaters. What are the causes of vision loss in a case of intermediate uveitis? Cystoid macular edema. It is the most common cause of dimness of vision. Other causes include cataract, especially posterior subcapsular cataract. Epiretinal membrane may lead to distortion of the vision, and if severe, dimness of vision. Media haze due to intense vitritis leading to vitreous wells and membranes. Wells is VEILS. Vitreous hemorrhage secondary to perivascular neovascularization. Media haze due to intense vitritis leading to vitreous wells and membranes. Vitreous hemorrhage secondary to peripheral neovascularization. Retinal detachment, tractional or rhigmatogenous retinal detachment, but that is rare in case of intermediate uveitis. So most common cause of, there are causes of loss of vision in case of the intermediate uveitis. So cystoid macular edema, it is the most common cause. The cause is cataract, subcapsular cataract, either steroid or inflammation cause. Epiretinal membrane, then media haze because of the vitritis, vitreous wells and membranes. Vitreous hemorrhage because of the neovascularization in snow banking. And retinal detachment, it is rare, but it can be there, rhigmatogenous usually. Other causes of ocular inflammation with white eye. So intermediate uveitis is one of the causes of white eye. So what are the other ocular inflammations with white eye? Apart from intermediate uveitis, other causes include Fuchs heterochromic iridocyclitis. Fuchs heterochromic iridocyclitis, one of the causes of anterior uveitis. Juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis, again one of the causes of anterior uveitis. Posner-Schlossman syndrome. Kawasaki disease. Fuchs heterochromic iridocyclitis. Juvenile rheumatoid arthritis. Posner-Schlossman syndrome. Kawasaki disease. Jammu Kashmir. Fuck Jammu Kashmir. Pose. Fuck Jammu Kashmir pose. Okay. Fuchs heterochromic iridocyclitis. Juvenile rheumatoid arthritis. Posner-Schlossman syndrome and Kawasaki disease. Fuchs heterochromic iridocyclitis, Kawasaki disease. J is juvenile rheumatoid arthritis. Fuchs heterochromic iriditis. Fuchs. Jammu Kashmir. J is for juvenile rheumatoid arthritis. K is Kawasaki disease. And POS means Posner-Schlossman syndrome. P, Posner-Schlossman syndrome. Fuchs hystochromic iridocyclitis, juvenile rheumatoid arthritis, Posner-Schlossman syndrome, and Kawasaki disease. So these are the ocular inflammation vitae causes apart from intermediate uveitis. Causes of intermediate uveitis at flowchart. Infectious causes: tuberculosis, Mycobacterium tuberculosis, especially in endemic countries like India, syphilis, Treponema pallidum, toxoplasmosis, Toxoplasma gondii, toxocariasis, Toxocara canis, Lyme's disease, Borrelia burgdorferi in endemic areas, cat scratch disease, Bartonella hansley, Bartonella quintana, human T lymphotropic virus type 1, human T lymphotropic virus type 1, HTLV1. Non-infectious conditions: sarcoidosis, multiple sclerosis, intraocular lymphoma. Idiopathic is pars planitis. Now, what are the causes of intermediate uveitis? Bacterial causes and parasitical causes and viral causes. Bacterial causes: tuberculosis, Mycobacterium tuberculosis, especially in endemic countries like India. Then syphilis, Treponema pallidum, toxoplasmosis, Toxoplasma gondii, toxocariasis. Bacteria. I just forgot the bacterial. Tuberculosis, Mycobacterium tuberculosis, especially in endemic countries like India. Then second bacterial cause is Borrelia burgdorferi, Lyme's disease in endemic areas. Then cat scratch disease, Bartonella hansley and Bartonella quintana. Then parasites and Treponema pallidum, syphilis, Treponema pallidum. These are the bacterial causes: tuberculosis, syphilis, cat scratch disease, Lyme's disease. Mycobacterium tuberculosis, Treponema pallidum, Borrelia burgdorferi, Bartonella hansley, Bartonella quintana. Then parasitical causes: toxocariasis, Toxocara canis, toxoplasmosis, Toxoplasma gondii. And viruses: human T lymphotropic virus type 1, HTLV1, human T lymphocytic virus type 1, human T lymphocytic virus type 1. Then non-infectious conditions: sarcoidosis, multiple sclerosis, intraocular lymphoma. Idiopathic or pars planitis. Non-infectious conditions: sarcoidosis, multiple sclerosis, and intraocular lymphoma. Sarcoidosis, multiple sclerosis, and intraocular lymphoma. Describe Kaplan's 4-step management that we have already discussed and described and read. Differential diagnosis of intermediate uveitis. Causes of media haze: old vitreous haze, vitreous hemorrhage, ocular lymphoma, amyloidosis, endophthalmitis, candida infections, Propionibacterium acne, endophthalmitis, leukemia, acute retinal necrosis, intense vitritis due to other causes such as toxoplasmosis. So, differential diagnosis of intermediate uveitis: causes of media haze, old vitreous haze because of the vitreous hemorrhage, ocular lymphoma, amyloidosis, endophthalmitis, candida infections, Propionibacterium acne, endophthalmitis, leukemia, acute retinal necrosis, intense vitritis due to other causes such as toxoplasmosis. Now describe steroid implants. So if there is intermediate vitreous haze is seen in intermediate uveitis, what are the other causes of the vitreous haze? Old vitreous hemorrhage, lymphoma, then leukemia, amyloidosis, then infections: endophthalmitis, candida infection, Propionibacterium acne, endophthalmitis, then acute retinal necrosis in case of the AIDS, and tumors, leukemia. Another infection is toxoplasmosis. Now discuss steroid implants. I have discussed these two, and they have written here that see above and chapter on diabetic macular edema. So Ozurdex is 1.7 mg, dexamethasone. Retisert is another, fluocinolone acetonide 0.59 mg. So what are these implants? Steroid implants, slow sustained release of steroids for a longer action. What are the side effects of steroids? What are the side effects of steroids? Ocular side effects: cataract, posterior subcapsular cataract, either because of the steroids or inflammation. Glaucoma, activation of viral keratitis, topical. Fungal corneal ulcer, central serous chorioretinopathy. Side effects of the steroids here, not the complications of uveitis, intermediate uveitis. So what are the side effects of steroids? Ocular side effects: cataract, posterior subcapsular cataract, glaucoma, activation of infections, viral keratitis, topical, fungal keratitis, fungal corneal ulcer, central serous chorioretinopathy steroid can cause. Systemic side effects of steroids: Cushingoid state, that is moon-like face, central body opacity. Diabetes, it can cause elevated blood sugar levels. It can lead to hypertension, low levels of the calcium, osteoporosis. Peptic ulcers, acidity, peptic ulcers, sodium and water retention, worsening of psychosis, menstrual irregularities, weight gain, thromboembolism, muscle weakness, aseptic necrosis of femoral head, pancreatitis, easy bruisability and convulsions, etc. So CNS side effects, starting from CNS: convulsions and mental worsening of the psychosis. Then another appearance: Cushingoid state, moon-like face, central body opacity. Then on blood, cardiovascular system, easy bruisability. Then aseptic necrosis of the femoral head, thromboembolism. Then bones and muscles, muscle weakness, decrease in the level of the calcium, osteoporosis, cardiovascular, hypertension. Then after that, abdomen, pancreatitis, kidney, sodium and water retention. And in females, menstrual irregularities, weight gain. So once again, what are the systemic side effects of steroids? First, central nervous system, convulsions. Then worsening of the psychosis. Then cardiovascular, first cardiac, hypertension. Then coagulation, vascular, thromboembolism, aseptic necrosis of femoral head. Then easy bruisability. Then appearance: Cushingoid state, that is moon-like face, weight gain, central obesity. Then muscle and bones, it can lead to decrease in the level of the calcium, blood levels, serum levels of the calcium. That can lead to the osteoporosis. Then mobilization of the calcium from the bones, osteoporosis. Then it can lead to the muscle weakness and aseptic necrosis of the femoral head. In abdomen, it can lead to the pancreatitis, diabetes, raised blood sugar level, abdomen, acidity, peptic ulcer disease, and kidney, sodium and water retention, and in females, menstrual irregularities. These are the systemic side effects of steroids. Here I conclude this intermediate uveitis chapter from Namrata Sharma. Hope you liked it. Bye.